Hello, everyone. Dr. Nikhil Verma here with another edition of Things I Didn't Learn in Med School. Today, I want to talk about and present this lecture that I had set up for the Fellows Retreat that I was previously on at the end of February. I guess it was actually the beginning of March. And I prepared this lecture to discuss with my fellows I had graduated from my program in the years prior, my experience and my pathway to private practice. I wanted to give some valuable information and some insight, as well as tips and tricks for people that are interested in their path to private practice. This will probably be a 4-part series just because there's a time limitation on how much I can record on the current platform I have. But also, I think I want to chunk it up to make it more accessible for more people and not having to sit through an hour long or an hour plus long lecture, just hearing me talk without having actually some actionable steps intermittently placed out. This will be on my YouTube channel, and it'll also be linked to some other tips and tricks that I have uh, to help in private practice. It's all under what's quoted as a private practice series or private practice recommendations on my YouTube channel. There's a separate subsection for that for anyone that's interested. I highly encourage you to go check out other videos that I've made in the past. So a little bit about me. This is my journey into medicine. Undergraduate at The Ohio State University, medical school St. George University. I did my residency at Kingsbrook Jewish Medical Center, which is now One Brooklyn Health. And I did my fellowship at Alabama Ortho Spine and Sports in Birmingham, Alabama. And now I am practicing Columbus, Ohio. That's a picture of me doing interventional procedure during my fellowship. Here's a little bit about my journey. I'm hoping that this cursor comes up on the screen when recording. I'm not quite sure if that is or isn't, but you'll see me starting in Columbus, Ohio. Actually, my first year of med school took me to Newcastle, England, and that's where I did my first year of bookwork. It was a pretty eye-opening experience. It was the first time I lived out of the country, and I met some great friends out there, core group of friends I still talk to daily. And yeah, it was a great experience to do my first year of medical school in that city. From there, the pink line, the peach line took me down to Grenada. That's where I did my second year of medical school. A very intense year for me. It took a lot of studying and a lot of staying disciplined. Not that the first year wasn't like that. I just feel like I had a better routine when I was there. The second year was a little bit more difficult for me, but not necessarily education-wise, just the volume of information that you need to know. From there, I did this green line took me to Brooklyn, New York for my years 3 and most of year 4 medical school rotations at the hospital centers, clinicals, as you will. From there, I went to Rochester Hills, Michigan, just north of Detroit for my intern year. After that, I went back to Brooklyn for my PGY 2, 3, and 4 years at Jewish Medical Center, Kingsbrook Jewish Medical Center, One Brooklyn Health. From there, that's the brown line to Michigan, yellow line back to Brooklyn, and then this gray line to Birmingham, Alabama. And then from Birmingham, Alabama, I came to Columbus, Ohio. So that's just a little bit about my journey. If anyone was interested, if you have more comments, questions, or anything like that, feel free to reach out. Here comes the crux of the lecture and the most important things I want to talk about today. And I guess anytime, one of the most important things that you need to decide before starting private practice is your location. Where do you want to be? Now, this may seem pretty trivial. People may say, I just want to live in this city or live in this state, which is fine, but there are things that you have to put into perspective and ideas that you need to be made aware of to make sure that this is going to be the best spot for you. This is broken down into these few bullet points here. I'll expand a little bit on more each. So the first thing is, what's the competition like in that area? The worst place to open up a ice cream stand is next to a world famous ice cream store. Now, I'm not saying that that wouldn't have benefits, but it may not be what may not want to go up against that competition. Now, a second worst place would be 100 miles from that store. Just because there's no one in that area, that doesn't mean that's so. We'll walk that back. And what I'm trying to say is, the reason why that store isn't 100 miles from that spot or 10 miles from that spot is because there isn't any traffic there. There's a good reason why places aren't putting up practices in certain parts of town or certain areas, just because the access is very poor to get patients there, and it's not necessarily going to be beneficial. So those are two things you need to think about. But if you do end up finding a spot that's closer to a big practice, there may be other things that you do individually in your practice that make you stand out. Are you an expert in regenerative medicine? Are you expert in longevity? Are you an expert in certain endocrinological diseases? Diabetes is super prevalent in the U.S. right now, and there's such a hard time getting into a good endocrinologist. Same with neurology. These are very, very niche topics that bigger groups may have a neurologist or an endocrinologist on staff, but you can really make yourself stand out by taking on patients and getting them in sooner than these other places can. If you're leaving another practice, you need to be concerned about a non-compete, but not only non-compete, but non-soliciting, where you are not allowed to solicit or bring patients from other practices into your new practice. These have less geographical limitations. This can be a hard stop, period. So say I want to open up, I'm in Columbus, Ohio. Say I want to practice in Cleveland, Ohio, and I was working for a group in Columbus. They can say I can't recruit patients to follow me to even Cleveland, versus a non-compete is usually limited to a mile radius, whether that be 5, 10, 15, 20, 50. Every non-compete's a little bit different. Referral sources. One big thing that I thought was going to be easy for me when I started my private practice was getting a lot of referrals because I'm so unique. I can get patients in faster. But that doesn't seem to be the case. A lot of physicians and a lot of groups have their own go-to person. And that could be in my realm of interventional pain and musculoskeletal health sports medicine. But that can also be in surgery. That can be in orthopedics. That could be in neurology. That could be in rheumatology. There's usually someone that they have a go-to. Now, as we expand in the multidisciplinary practices and the medical industrial complex, the bigger groups try to acquire all those specialties within their group so the patient doesn't ever have to leave that group. Now, I have talked about why I find this problematic in the current medical state. That's a lecture for another day and another time. But just realize that is going on. And if I give you an example, in Columbus, Ohio, the main primary care group, they have their own interventionalists, and they just refer to them. And that makes it difficult for me to get referrals from those primary care physicians. On top of that, there are this primary care group has a private equity partner. Now, this private equity partner group also has ties with another private equity group. They may even be the same private equity group, and that other private equity group has ownership in orthopedic, the orthopedic group in the area. So now that those two talk, any patient may go from one to the other any patient that's coming from that primary group might just go to that orthopedic group and get in their network. So it gets very difficult for a small private individual practice to get these patients. Another thing to think about is insurance mix. Um, you may go to an area that might be a little bit underserved, and you'll get a lot of patients with the Medicaid and Medicare's, and that can be a very lucrative uh, proposition for patients or physicians, especially providing care to patients that need it. Now, these types of patients come with their own problems, especially in underserved areas, because they tend to be the ones that don't have good healthcare education, and they don't have a lot of resources to maintain good health. So it adds a layer of complexity for the physician, and it can end up taking more time. And unfortunately, the reimbursement for them compared to a private insurer can be a lot less. But when I'm saying insurance mix and payer mix, what I'm actually referring to even more so is sometimes in those areas there will be a population that works for a factory or a big store in that area, and they have employer-sponsored health insurance, and those can be pretty lucrative as far as getting good insurance rates. Now, getting into the networks of those, I'll talk a little bit about on the next slide, but just something to keep in mind of this. That's what I mean by insurance mix. How much Medicaid are you seeing? How much private pay are you seeing? How much private insurance are you seeing? How much Medicare are you seeing? Um, this data can sometimes be very difficult to find, but there are tools out there that can help you find it. Not something that's my specialty, but I've talked to some business and practice consultants, and they're the ones that have made me aware of this. Credentialing and network participation. This is something that you need to decide before if you're going to go in network with insurance or out of network insurance. It takes 6 to 9 months to get these, maybe longer, to get these credentials from insurance companies. And so it's really important to start this process early. And then other things, you need to start realizing what state requirements do you need in that area. So this next slide, talking about credentialing and contract networking with insurance companies. One thing that you need to acquire is a group NPI number, and that's going to be your billing NPI number that's going to be submitted to these insurance companies. You'll retain your individual NPI number, but for the most part, you'll be billing under your group NPI number. To get some of these NPI numbers in your insurance contracts, what you need to do is you'll actually need an address, a phone number, a fax line, all these things. And even when you're starting an actual business and applying for the business license for your states, you're going to need all these things. You might need other state recommendations and other state required documentation, such as business liability insurance, medical liability insurance. You might need permits to sell things. You might need permits to practice medicine. For my office, we have a fluoroscopy machine, which is a CR machine that needs special radiological licensing from the state. You'll need some states require a terminal distribution license if you're prescribing medications or if you're injecting medications at your office. Even if you're not, Henry Schein, who is a medical supplying distributor, will ask you to submit a terminal distribution license to them, or to opt to say that you're exempt for those situations that you are exempt. So that's something to look into with your usually your state pharmacy board. Creating a fee schedule. This is something that is needed for the insurance company, something that they want to take a look at. The fee schedule doesn't necessarily mean that that's what the insurance companies are going to pay you, but it is a negotiating point and a contracting point to set this fee schedule just in case. It also becomes beneficial when you're working with workers' comp cases and personal injury cases to set a fee schedule and you're not just making this up. It can also be very important for the No Surprises Act, where you have a actual fee set in case insurance doesn't cover it. So that way you're not overcharging patients and there's no surprises for the patients when they get a bill. Again, I talked about 3 to 12 months per insurance contracting. Many states will vary. One issue I ran into was in Ohio, the panels were stating that they were out of network, or their panels were closed for PM&R doctors, or sorry, interventional pain doctors. So I reached out to all these insurance companies, the ones that denied it, and stated, like, I'm actually a PM&R doctor who happens to have interventional skills and training. So I use that as my leverage point. And then I also see PM&R patients in my clinics, post-stroke patients, amputee clinics, and these kind of patients. So I was providing a service that actually there wasn't any in my area. So that would help me credential in this area. It's super important to keep the hard copies of all your contracts, and you're going to need this for negotiations. In Columbus, in most states, you need to be credentialed with a hospital in order to open up a practice, or even if you're not working at that specific hospital. You need to have these credentials to see patients, I should say. This is quite often in a lot of states, and one thing that was told to me recently was, if you take a delay of setting up credentials at a hospital, it can cause you to never be able to get credentials with the hospital in those states, and therefore you do not see patients. Another thing, if you're working at a ambulatory surgical center, that's going to have its own credentialing process, so keep in mind about that. And I talked briefly about in-state or in-network, out-of-network. Again, if you're in network, you can see the patients at the contractor rate. Some practices, especially in certain areas that it gets hard to get into network, is you just go out of network. Some patients have out-of-network benefits, and it works out great for the physician and the patient. Other times, patients just want the services, and they don't necessarily care to pay the 1.5 to 3 times the CMS rate for services. And it can be beneficial in that way when going out of network. Now, patients can also submit their super bills to their insurance companies, and the insurance company can still decide to pay it or not. If the insurance decides not to pay it, then the bill falls on the responsibility of the patient. Not something that is very popular, especially in states that a lot of members of the state are reliant on the medical insurances, but it can be something that is beneficial in spaces that have higher wealth, I should say. Next thing I want to talk about is, just website, brand, online reputation, and a domain. There are companies that can handle all of this for you, varying degrees. Some are better than others. If one of the most important things is actually grabbing a domain that is either for your practice or for yourself. So, for example, mine could be nikhilvermamd.com or something along those lines. And grabbing those domains is very important. You can have companies like Fiverr or Odesk set up the websites and run them and operate them at a very relatively low cost. Mainly, they're just an upfront fee, and then the maintenance fee is a lot cheaper. The next thing is having the reputation, making sure your WebMD profiles are up to date, having patients leave reviews. You'll see some of the example of reviews down here and on my Instagram page. I also have a social media X page. I have Instagram, and my social media on Facebook. I also have this YouTube channel. So all these things are part of my website, online reputation, brand. They all go together. A couple of comments of the HIPAA laws. When you're posting things on social media, it becomes very very tricky how you want to answer patients that leave you reviews, good or bad. You cannot qualify a patient that has actually been seen by you. So if Joe wants to leave a comment on my section, 5-star review, had a great time with Dr. Verma, et cetera, et cetera, I can't say, hey, Joe, it's great to see you. Thanks for the response. All you can really say is, thank you for your response, or we appreciate your feedback. You can't really directly say that this is a patient of yours because that is a violation of the HIPAA laws. And also with the negative reviews, you can't go back on a patient and say, well, the reason why you had to wait so long was because the doctor got busy and was falling behind, and we're sorry for the inconvenience. All you can say is, we appreciate your feedback, or if you have any concerns, please contact management. So that's something to keep an eye on. You want to be careful about posting things on social media, about posting patients without their consent. A lot of patients will give consent, but make sure that they do before you post anything. Those are times you can obviously put things on social media and show a patient is a patient of yours. One thing that I see quite frequently, and I find it humorous, is that a lot of pain physicians or other physicians will post pictures of procedures, and not of the patient's names, but maybe the fluoroscopy images with contrast red or end results after they're done with the procedure, and how blatantly wrong their interpretation of the imaging is. Or how I quite often see people posting on Instagram pictures of really cool procedures, really interesting procedures, but their technique has no validity, not even knowing how that technique is taught or what they're actually looking at. So a lot of these times you're boosting things, and it can cause problems because if for whatever reason that procedure becomes under scrutiny from the government, and someone, not even the government, or you're in a lawsuit or whatever, um, or the patient's unhappy, if that image was seen by a consensus of physicians of that practice, of that practicing specialty, you would not have no basis to protect yourself. Um, and that's a fair warning to be careful of what you're posting on the internet for those purposes. Another thing I want to just briefly talk about here is noticing that my logo here at the Essential Sports and Spine Solutions, you'll see that kind of posted everywhere. But it goes a step beyond that, because when I made this logo, all those things, the color palettes, the font, the type of font, all of that is reproduced in anything I post. So if you'll go to my web page, if you go to my Instagram page, unfortunately, I don't know if I could do it on YouTube yet, but these are all the things that are the same colors and the same font. So I use the consistency of the font and the colors over and over and over again, just for that reason, for consistency, and makes it seem uh, more seamless across all the platforms. Now, one thing that I just thought about right now that I should be doing is, when I make these AI generated images, I should really be using those same color palettes and the fonts as much as I can into those to continue the consistency of things. So, I think that's probably a really good spot to stop today. It's been about 25 minutes. Next time, I'm going to start talking about some hiring and go into a little bit of detail for that. So again, I really hope you guys enjoyed this. And if you are starting your private practice, you may want to go back through this a few times. If you have questions, feel free to send me a message on Instagram, through YouTube, and we can definitely discuss more. I think it's super important to put in right now that um, if you are starting a private practice, I think it's important to go through these videos that these make, because it's going to not only help you learn from my mistakes, but towards the end, I think it's going to be the most important one, the last video that I produce of this. Um, it's going to be the most important because there's a lot of insightful things that when I made this presentation, after the presentation was done, I had people come up to me after the presentation and say, your presentation was great. I really appreciate it. But it was that last thing you said about the last slide that really really made me reconsider my life and what I'm doing. Um, and I think that's an important message, not only for people that are considering making the leap, but also those people that are in medical school and um, in residency, or just finishing a fellowship, or been in practice for a few years now and ready for the next move. So I really hope you watch that one and get that same feedback. So, anyways, everyone, it was good to talk to you. I'm going to try to get these out every week, if not every other week, and we'll talk to you soon. Take care. Bye.